We'll have a session now for an hour and a half, starting with a presentation, short lecture, and then we'll have the free papers. And I'll remind the speakers of the free papers that you have 6 minutes for your presentations, and please stick to that so that we can keep the timetable and have some time for discussions and questions. It's my pleasure to introduce to you Dr. Kazzi Schuind from Brussels in Belgium, who is our first speaker this morning, and he will talk on new techniques of osteosynthesis of the distal radial fractures. What is the evidence? So please.
Thank you very much. Good morning. The distal radius is the most frequently injured bone, as you know. We know also that non-operative treatment leads to up to 60% of secondary displacement. Even non-displaced fractures can redisplace on the plaster. And we know that malunion is not very well tolerated, especially loss of radial length, except in elderly patients. Palmar locking plates are presently very popular, and there is an extensive literature, but there are few evidence-based trials comparing techniques. The Cochrane review of 2003 was split into several separate reviews, and I will try today to discuss the choice of operative method and the complications. Indeed, many techniques are available. There is an agreement to treat Volar Barton shearing fracture by plate fixation. For extraarticular distal radius fractures, actually AO type A fracture, you can do whatever you like. You can do Kapenge, intrafocal pinning, locked or unlocked palmar plate, external fixation, endomedullary fixation, even only use bone substitute like IDA recommended. Some comments, however, dorsal plating is not very popular anymore because of tendinous complications. There are risks with the Kapenge technique of EPL synovitis and rupture, and also a risk of either hypo or hypercorrection with difficult malunion. The problem is actually the comminuted displaced articular fracture of the distal radius. I think nowadays there are two techniques that are suitable for this fracture, which is external fixation on the other hand and pre-contour locked volar plate on the other hand. External fixation could be either radiometacarpal or bridging external fixation. Actually, non-bridging external fixation is not suitable for comminuted articular fractures. It is for extraarticular fractures or for corrective osteotomies. We classically believe that the reduction in external fixation is obtained by ligamentotaxis with traction on the preserved capsular and ligamentous structures. However, the extrinsic wrist ligaments have an oblique orientation, they are frequently ruptured, and the ligaments do not insert around the whole distal radius extremity. So we have hypothesized that there could be a potential role of a negative joint pressure during reduction, pulling the small fragments into place. To investigate this, we have used this catheter, allowing the measurements of the pressure within the radiocarpal joint, here in clinical case. And we have demonstrated actually that during the reduction, the pressure within the joint diminishes quite a bit. Then this is what happens when you lock the fixator, and when you unlock the fixator and lose the reduction, then the pressure goes back again. So we have done the measurements in 10 patients, and you can see that during distraction, there is a major decrease of the pressure within the joint, susceptible to reduce the small articular fragments. And if you only do palmar flexion, the pressure is markedly increased. Whatever the mechanism of reduction of the fracture, I believe the best indication of radiometacarpal external fixation is the highly comminuted fracture treated within the first days after the accident. A few examples. Other indications are open fractures, fractures with associated lesions of the forearm and hand, and polytrauma patients. The principles of external fixation: first, it is a KISS technique. I mean, keep it simple and safe. Second, you have to prevent the radial neuroma during careful insertion, proximal insertion of the radial pins. It is useful to do a postoperative CT scan to verify the quality of the reduction. You should install pin skin exit care to prevent infection. Install also early finger motion and release the distraction at 3 weeks to prevent CRPS. And the external fixator is removed after about 2 months after early bone healing. There are complications including pin site infection, digital stiffness, and CRPS. Locked volar plates are based on the concept of one unit to hold the bone fragments, including the plates and the screws or the pegs. This is completely different than conventional plating. It is helpful to do a preoperative CT scan. You do a palmar approach. If needed, you release the insertion of the brachioradialis. It is important to support the radial and the intermediate columns and to perfectly place the plate in the pronator fossa. The locked Finks angle and or polyaxial screws or pegs should not be too long distally to prevent dorsal tendon lesions, and in case of synovitis, it is recommended to remove the plate after 4 to 6 months. There are some complications, up to 27%, intra-articular penetration of the hardware, rupture of extensor tendons in case of too long bicortical distal screws, flexor tendon synovitis, carpal tunnel syndrome, rupture of the flexor pollicis longus, depending on the implant roughness and on the plate positioning. If it is too distal, this is a problem. There are also cases of loss of reduction and a lot of other complications have been reported. In the literature, you find 3 meta-analyses. The first one concluded before the time of the locking plates that external fixation was better than internal fixation, and 2 other meta-analyses from Margaliot and from the Cochrane could not conclude that one method was better than the other one. There are also some prospective series comparing both methods. Kreder compared 2 groups of patients, one with open reduction with usually plate fixation, another with closed reduction with, in most cases, external fixation. And he found better function in the cases treated by closed reduction and usually external fixation, provided that a good reduction had been obtained. So he recommended to choose external fixation in the case of insufficient reduction to proceed then to plate fixation. Leung compared conventional dorsal or volar plate with augmented external fixation and found better results and less osteoarthrosis after plate fixation. All dorsal plates were removed in this study at 6 months. Egol compared locked volar plate and augmented external fixation. Despite randomization, there were more comminuted articular fractures in the external fixation group, so more complex cases. He found slightly a better range of motion after plate fixation at 1 year, but it was only a few degrees, so it was not clinically relevant. No other difference, and he had more reoperations in the plate group. They compared plate, volar or radial and augmented external fixation. The dash was better, but only at 3 months after plate fixation, and thereafter there were no differences between both techniques. We submitted for publication this study. We compared locked volar plate and external fixation. Actually, we matched 25 patients in each group for gender, for age, and for eotype. So 25 patients were operated in Kortrijk by locked volar plate, and 25 similar patients were operated at our institution by external fixation. We found slightly better anatomical results after plate fixation concerning the volar tilt and concerning the radial height. The functional results, there were a better range of motion after volar plate, but only at 3 months, no difference thereafter. The grasp strength improved in both techniques, but remained significantly better after volar plate at 1 year, and also the dash was better at 1 year after volar plate. However, we should comment that this study was carried in 2 centers, one private in a small city and one in a big metropolitan area, actually Brussels. So the populations were different, and also plate fixation was applied by experienced consultants, while external fixation was applied by trainees at our place in duty hours. So we need really a prospective randomized study in one center by one team. About bone graft, well, the Cochrane concluded that there is presently no evidence to recommend in these fractures a systematic or occasional bone graft. In conclusion, for what concerns the treatment of comminuted displaced articular fractures of the distal radius, two methods are still very good, I think, ready-made carpal external fixation and locked volar plate. Actually, the other methods lead to an unacceptable rate of complications up to 50%. Locked volar plate is the present fashion, and the reduction, the quality of reduction and the functional results might be slightly better on average than external fixation, especially in the first months, but on the long term this remains, I believe, to be demonstrated. The implants, however, are expensive. There is a necessity of hardware removal in many cases. It is not really a case technique, and it can be difficult, especially to apply in extremely severely comminuted distal radius fractures. And my opinion is that there is no indication of bone graft or bone substitution. So our approach is still to use external fixation, but in the case of more comminution, to add, if necessary, plate fixation, keeping, if necessary, the external fixator. Thank you very much for your attention.